Hello everyone, in this video we are going to talk about hypothyroidism in the pregnancy. Though I have a video previously on thyroid disorders in the pregnancy, but this video will act as a addition. Now, it's a very common disorder, very common to find a hypothyroid ladies in pregnant population. So now let's discuss what can be the reason. In the countries like India, where the iodine deficiency is still not a very uncommon, iodine deficiency is there. But what actually happens that the iodine deficiency and the hypothyroidism is a subclinical thing. Okay, so it's not detected. So once that lady becomes pregnant, now all the tests are being done, and that time you will find that the hypothyroidism is there. So the most common reason in countries like India or developing countries is what? A subclinical hypothyroidism, and most of the reason of that is iodine deficiency. Okay, now also in developed countries the most common reason would be Hashimoto's thyroiditis. Hashimoto thyroiditis is the disease which is autoimmune disorder, and it destroys the thyroid gland. The antibodies are there against the thyroid proteins, like thyroid peroxidase enzyme. Thyroid peroxidase enzyme is the very center of the formation of the thyroid gland, so that's why that enzyme is gone now. So that enzyme is being reduced by this autoimmune antibodies. So that's why the production of thyroid hormone is decreased. So this is why the hypothyroidism is there. Again, this can be subclinical, and it can come into light when the patient becomes pregnant and we do our investigations. One very basic thing about the thyroid physiology in pregnancy is that there is an increased requirement of thyroid hormones T3 and T4. Okay, why? Because the thyroid binding globulin is increased. The level of thyroid binding globulin is increased. I think it is triple the previous values. So to bind those TBG, you need more and more thyroid hormones. Iodine is being loose in pregnancy due to hyper due to the renal hyperrenal excretion. Okay, fetus also needs thyroid hormones and iodine. So all these factors will make a patient hypothyroid. Okay, and sometimes it reveals on first time. So all these reasons are all with the hypothyroidism. Now understand uh, the game between TSH and T3 and T4. Okay, now what is the game actually? Here, the pituitary secretes a hormone that is TSH. TSH will act on the thyroid gland to secrete T4, T3. Now T4, T3, the free T4, T3 will do what? Regulation by negative feedback. Okay, so what actually happens is when you start investigating hypothyroidism, the first investigation of choice is TSH. The TSH will give you a larger idea of thyroid status. For example, if the TSH is higher, then you know this thing that the negative feedback by T3 and T4, free T3 and T4 is less. Okay, so the first investigation is TSH. If TSH is increased, then you go for free T3 and T4. If free T3 and T4 are decreased, and at that time you start thinking of hypothyroidism, and it is the diagnostic of hypothyroidism, that the free T3 and T4 level are decreased, that is diagnostic of hypothyroidism. Okay, now for investigation purpose to rule out Hashimoto's thyroiditis autoimmune disorder, you also go for one more investigation, that is anti-thyroid peroxidase antibodies, anti-TPA, which gives the report they might be positive, they might be negative. Okay, with all these the findings, once the diagnosis is established that there is hypothyroidism, you can start the treatment. It's very easy. Levothyroxine is available routinely available. The tablet doses are 25 microgram, 50 microgram, 100 microgram, like that. You need to do a dose titration. For example, if you come in the contact with a patient who has a TSH level 7, then what will you do? You will start levothyroxine like 50 microgram, and then after 1 month you will again do a TSH repeat test. If TSH has been come as 3, then it is taken as a normal, then you can continue 50. If after one more month, if it is say less than 0.2, then you need to decrease the dose from 50 to 25. This is how you titrate the thyroxine doses. Now, recommended level of TSH in first trimester are 0.1 to 2.5, second trimester 0.02, 0.2 to 3, and third trimester is 0.03 to 3. So what you can see here, the TSH more than 3 is considered as a hypothyroidism, and you should start treatment once you finally establish the diagnosis. So 2.5 is the limit in first trimester. The first trimester is very important, where the baby cannot produce its own thyroxine hormones and dependent on the mother thyroxine hormones. So in that particular trimester or the first trimester, the thyroid hormone should be normal. So the threshold is 2.5 here. Okay. Now, if the patient you can identify as an iodine deficiency, then you can give them the idea how you use the thyroid. For example, a pregnant woman needs 250 microgram per day iodine. The lactating woman also need 250 microgram iodine. Okay, so have this understanding of how iodine supplement can be given. Now, the foods which contains the iodine are, if the patient have no problem in non-vegetarian, then fish is a very important source of iodine. If the plant-based food sources of iodine are what? Plant-based food sources are what? Broccoli, strawberry, spinach, potato are the sources of iodine. So this is how you manage a case of hypothyroidism. Thank you, friends.